disclosures are the same as yesterday. And the performance objective, we really have one: develop effective personalized treatment plans for patients with chronic infection based on interpretation of the timeline, the ATMs, the physical exam, laboratory analysis, and clinical matrix. So, hey, we have an hour, so this should be easy, right? Except there's a lot to do. So I talked about this yesterday, right? We take the case. And what does that mean? It means you shut up. It means you listen deeply, right? Don't be thinking about what you want to say. Think about what the patient is saying, and then transfer that to a timeline and a matrix, and always searching for antecedents, triggers, and mediators. And why am I saying all this stuff again? Because this is super important. This is the real deal. Bob and Kara and Helen have done a tremendous job of talking about all these really detailed pieces, but those details fit on this framework. And this is really how all of us treat this chronic disease. So we have, the biochemistry and the biological plausibility and the clinical evidence for all these botanicals and all the things that have been discussed, but we hang it on this framework. And then it's really important. These people come with a boxcar full of baggage, and we need to vet that stuff. We need to figure out what diagnoses are real, which ones are plausible, which ones are just not true, and make sure the patient understands that. And that needs to become part of their story. And then we need to remember that unless there is a compelling reason to do otherwise, we start in the gut. And we remember that the case evolves. So we are really running laps around the matrix, because at the beginning of these complicated cases, it feels like you're playing whack-a-mole, because you make a little change over here and it causes a change over here. And then you make a change over here and it causes a change over here. And you're just running circles around this matrix. And that's pretty normal in these complicated cases. So most chronic infection is really a failure of the immune system, the terrain. So before looking for bugs, we need to optimize the terrain, which is all of the functional medicine tools we've talked about. And then this is important because not only will it make the treatment of the infection more effective, it will reduce these Juris-Herxheimer type reactions. And then remember that don't do what I did when I was a resident. When I was a resident, I had a patient in the ER and I put a needle in his back, and instead of getting this beautiful, clear spinal fluid, turbid, white, pussy spinal fluid came out. And I waited for the gram stain, because that's what we were told, wait for the gram stain, wait for the gram stain. Well, luckily he didn't die, right? But he had obvious meningitis, and he should have been put on, high big gun antibiotics right away. A chronic infection is different. We're talking about chronic infection, not acute infection. So we do all of this stuff, and then, so we apply the functional medicine model, and then we search for bugs. And we search for bugs. And the beauty of this is it takes a while to find these bugs. So you've got a lot to do before the cultures and the tests and everything come back. But then the test comes back and you decide, well, how do I figure out how to treat this? Well, there's lots of references. The Sanford Guide to Antimicrobial Therapy is a little one you can carry in your pocket or on your phone. And then, of course, the Natural Medicine Database is part of your membership with IFM. And then my approach to the chronic Lyme. I did a video not too long ago where I said at the beginning, if you're following a protocol for your chronic Lyme, you're not going to get better. And here's why. It's because this page is my protocol for Lyme, but the real protocol starts at step 1, which is all of the functional medicine stuff. All of the functional medicine stuff is the important part. And then this is trying to keep the bugs entertained while we kill them with our own immune system. So all the above in that order, all the functional medicine stuff. And then we cycle antimicrobial 6 weeks on and 2 weeks off. Why? Because we've found that the persister forms that we talked about yesterday tend to show up during the flat part of the curve. So there's exponential growth, and then it flattens out and becomes static phase, or whatever you want to call it. And the persisters are most prevalent in that phase. So we use 6 weeks of antibiotics. We beat down what bugs we can. We let the antibiotics wash out. All of the quorum sensing stuff that Helen has talked about and I talked about yesterday, all of that stuff happens, and they auto resuscitate. They come out of their hiding places. The persister forms kind of go down in number, and then we hit them again with antibiotics or antimicrobials. So what antimicrobials? Stevia. Nutramatic stevia specifically, stevia 15 drops BID, oregano, or actually my favorite is the liposomal form of biocidin, 2 pumps of that twice a day. Colloidal silver, 1 ounce, yes, 1 ounce per day. Now, you're not going to turn people blue with this. You know, those people on TV who turned blue, they were putting it on their skin and they were getting into a tanning bed. They will easily detoxify this dose. And we're talking, when I say colloidal silver, we're talking about the 20 parts per million. So not, you know, some super high dose, but you will easily detoxify that level of silver every day. And then add antibiotics if necessary. So Bioxin in the summer because it's somewhat less photosensitizing, and Doxy in the winter because it's more photosensitizing. Now, what about some of these advanced antimicrobial strategies? So here's the Horowitz triple intracellular stuff, Dapsone, Doxy, Rifampin. So Dapsone has antibiofilm properties and other anti-persister forms. Plus, these are the Dapsone is a intracellular antibiotic. So in vitro data shows really no synergy with this combination. Dapsone alone at 10 or 50 micromolar showed residual growth of 69 and 58%, and the combination showed 78 and 52%. And all of this had approximately a 5% plus or minus 5 standard deviation confidence interval. Clinical claims in a retrospective study, about 98% of patients had improvement initially, and about 58% improved at 1 year and beyond. That's pretty good. More than half of people got better in chronic Lyme. That's good. My clinical experience in my office has not been that impressive. I do use this in my most recalcitrant cases. And then what about the next wonder drug in the Lyme market, which is disulfiram? Disulfiram was found on a high throughput study to be basically 100% effective. A retrospective review of 71 patients showed 4 lost to follow-up. 33 were able to get to the target dose. So 46% of people got to the target dose. 12 had sustained remission greater than 6 months. 13 received more than 1 course. So from an intention to treat perspective, 12 of 71, 17%, had remission greater than 6 months. So my clinical experience, it's hard to get people to a target dose. Side effects are significant. And I'm about to say that the 17% improvement might not justify this drug. Having said that, these patients are often very difficult, and I use disulfiram. It's like my 3rd or 4th or 5th line treatment, and I just started somebody the other week on this. Because if your patient happens to be in that 17%, it's pretty miraculous. And as we'll see with other therapies, as we go down the list, sometimes we pick up a few more wins, right? So according to the My Lyme Data Project, which is a project of where's my brain gone? With the LymeDisease.org. My Lyme Data is sort of a big data project, and this is an interim analysis while they're collecting cases, right? So they have just under 2,300 patients. 41% are non-responders. 17% had a low response to antibiotic therapy. 36% were high responders, and 6% did very well. So overall, those high responders and the people who were just essentially cured by antibiotics, that was 42%. So 41% non-responders, 42% were responders. Now, if we look at Dr. Rose's comment, who is from GlaxoSmithKline, he says the vast majority of drugs, more than 90%, work in 30 to 50% of people. The drugs out there on the market work, but they don't work for everybody. And you'll notice that these antimicrobials here appear to work in that zone of 30 to 50%, right? So it's not really surprising. Now, MyLyme data here again. Long-term antibiotic therapies are associated with better outcomes. 71% of well people and 37% of high responders had antibiotics for more than a year. And those treated for less than a month were unlikely to report improvement. Now remember, we're talking about chronic Lyme here, disseminated Lyme. We're not talking about acute Lyme. Again, from MyLyme data, a high percentage of patients in the well and high responders used a combination of antimicrobials and alternative therapies. 51% of the well and 48% of the high responders used alternative therapies. So what did they use? They used herbal protocols. They used sauna. And in this case, sauna, I think, is really another kind of detox. And they used chelation and other detox. By the way, EDTA is one of the best biofilm addressing agents. So it may be more than just detox if you're using EDTA, chelation as an example. Medical marijuana. Well, is that just a symptomatic control? Well, maybe, but we know that the cannabinol pathway reaches into the immune system, right? Acupuncture, homeopathy, nutraceuticals. I wasn't able to ferret out exactly the difference between nutraceutical and herbal therapy, but let's just say that that whole genre appears to be pretty effective. Electromagnetic therapies, hyperthermia, oxygen like ozone, rife, colloidal silver, and then hyperbaric oxygen. I spent $300,000 to put hyperbaric chambers into my practice. And, you know, for those people it works, it was miraculous. 22% of people who used it, they felt like it was really miraculous. So I use it for a lot of other things, and it's down lower on my list for hyperbaric. And what I really want you to look at is stem cells. You know, stem cells are all the rage. This is probably one of the largest catalogs of did stem cells work for Lyme. Several hundred patients in this cohort tried stem cells and only 3% thought it helped them. So here's a few references. And so rarely do I have to go to these big guns because we're doing aggressive functional medicine therapy and we're lapping the matrix. And what is functional medicine really doing? Well, we're assessing detox. We're using herbal protocols. We're optimizing, you know, everything in the matrix, the energy pathways, all of that stuff. So, you know, I think we're doing the things sort of instinctually that are on that list from the MyLyme data. And don't forget, unless there is a compelling reason to do otherwise, start in the gut. And don't forget, we talked about colostrum and colostrum-like products being a great biofilm treatment as well as being good for the gut. And we need to lap the matrix. So how do we do this? Well, we talked about this yesterday. We're going to manage the entire matrix aggressively, right? And at first it's like whack-a-mole because you do something in the gut and it flares up something else, or you do something with hormones and it flares up something else. So we're going to count all these. So we've got 18 areas of just functional medicine interrogation, right? We're going to do the whole meal deal here. And again, looking at sort of how personalized is this? This is a highly personalized intervention for these people. But now we add the idea of getting some labs. And instead of looking at 18, 19 areas, now we're looking at maybe 30 areas because we're looking at, you know, are we treating Lyme? Are we treating co-infections? Are we treating viruses? Are we treating imitators? You know, are we treating their organic acids, whatever. So now we're hyper personalized. And then how long do you treat? And how do you know if the patient is getting better? Because these people get better slowly. And, you know, one day the person will come in and say, my brain is so foggy, I can't function. The next time they come in, they say, you know what, my brain functions pretty good, but my joints hurt so bad, I can hardly function. So, at first I was, again, it's playing whack-a-mole. First, this is bad, and then this is bad, and then this is bad again, and then something new is bad. So instead, I went to asking about their wellness. So 0 to 10, 0 is I cannot function from any cause. And 10 is I have perfect, vibrant, effortless health. Why effortless? Because these people are used to being active, right? And they get to a point where they say, well, I just push through, so I guess I'm a 10. No, effortless. So, effortless, that means I'm a 3, right? And then I expect really nothing out of them in the first 3 months because they're going to have Herxheimer reactions. They're going to have, again, we're doing this bio warfare in their bodies, right? And we need to talk about this up front. So people who come to me, they can fog a mirror, but not much more. They're like a 3, right? 3 out of 10 in wellness. And I say, okay, you're a 3. That means we have 7 to go. The first 3 months, you're not going to get better. And so at that rate, 1 every 3 months for those 7, we're talking about 24 months. We're talking about treating you for 2 years. And I tell them that on the first day, the first day we diagnose Lyme, and I tell them that at every single visit. I also tell them that it's easier to get the first 3 than the last 3. And we'll see that in the case as it progresses. All right. And then I already told you I expect 1 on every 3 months. And don't forget modifiable lifestyle factors. We talk a ton here about nutrition, and we talk about these others, but I just want to emphasize sleep and relaxation. A great book, Why We Sleep by Matthew Walker, PhD. He's a researcher at Berkeley. Sleep reaches into every aspect, every aspect of the matrix for sure. And if you're not sleeping, your immune system's not going to work well. Your repair is not going to work well. Your detox is not going to work well. So sleep, exercise and movement, we talk about sub-symptom threshold exercise. So, your patient says, if I go just to the end of the block to get my mail and come back, or the end of my driveway to get my mail and come back, I crash and burn for 3 days. So that's the symptom threshold for exercise, right? So what's half of that? That's what you're allowed to do. And so in those really, really sick people who are a 3 out of 10, their exercise program is, get to the bathroom before you have an accident. That's their exercise program. But then as time goes on, their ability to do things increases, right? And as they get probably closer to a 5 or a 6 or a 7 on this, we can start to escalate the amount of work up to about 80% of whatever their new threshold is. So, but this is the art, right? It's for chronic fatigue, the art is different than for chronic Lyme. Now, what about stress? A great book regarding stress. There's a few. One called Radical Acceptance by Tara Brach. Another called The 4 Agreements by Don Miguel Ruiz. And then for relationships, Don Miguel Ruiz's book, The 4 Agreements, is a relationship book, and The 5 Love Languages. So, you really need to dive into these and get some systems in your office to help people with these stressors, because these are crucial to getting better. And some more references. And let's meet John, 52-year-old gentleman, PhD, chemist, head of a lab at a Fortune 500 company. He's an avid outdoorsman. He's a hunter. His symptoms onset at about 2000. He had the slow onset of fatigue, cognitive difficulties, roving joint and muscle pains, and plantar fasciitis-like symptoms. Within about 3 months, he had severe insomnia, mood disturbances, irritability, depression, anxiety, and he just felt like he couldn't really even do his job. He was really getting concerned. His symptoms were interfering with his family life, and his fatigue, cognitive pain, and so on were all getting worse with time. So he struggled with his primary for some time with this, and then he was eventually sent to a rheumatologist who said, not sure what's going on, but it looks like it might be seronegative RA, and treated him with some meds. He went to a neurologist. The neurologist said, gosh, I don't know, don't see anything. And a psychiatrist said, well, clearly you're super stressed and depressed. So he's put on meds for that. So over the next 18 months or so, he battled with these progressive symptoms. He was tried on multiple medications with little help. He asked for help from a friend in his lab, a fellow PhD chemist researcher guy. And he looked high and low, and he came up with all kinds of things that he tried, but he finally found this sort of fringy deal about chronic Lyme disease. So the John went to his primary care doctor and said, gosh, can I get a Lyme test? And the primary said, I don't think this is Lyme, but sure, I'll do it just because you've been a patient for a million years and I know you're sick. Returned negative. So the colleague told him that apparently just like RA can be seronegative, apparently people are talking about how Lyme can be seronegative. So they found a Lyme literate doctor, and the Lyme literate doctor listened to him and ordered an IGeneX immunoblot. And that was positive by alternative criteria. So when you do these tests, most of the labs will have the CDC criteria, and then they will also have their alternative criteria. So it wasn't positive by CDC criteria. So he the Lyme doctor started him on triple antibiotic therapy. Unfortunately, John had tons and tons of side effects to that. And because he was really skeptical of the diagnosis, he was unwilling to tolerate the side effects. This Lyme doctor and John worked together for about another year on various antimicrobial strategies with no lasting benefit. He was seen by several more providers for Lyme disease, mold toxins, mast cell activation, chronic fatigue syndrome over the next several years. And while he had varying degrees of success with treatment, there was really no long-term success. And his colleague, again, this is a good friend. This guy is digging into it, and he learns about functional medicine. Actually, my understanding is he saw a presentation by Dr. Mark Hyman, and they found a local functional medicine provider, and they started working together. And because of this lecture, in fact, that this provider saw, he referred him to me. So guess what I did? Well, I took the case, right? I did all the things I talked about. I filled out a matrix. I did all these things, right? And so here we are. Just to reiterate a little bit, John is a regular visitor to Lyme endemic areas, northern Minnesota. His symptoms onset, as best as he can recall, was probably about 3 weeks after a hunting trip. He had no rash and he has no recollection of a tick bite. In fact, he emphasized that fact, and that he had a negative Western blot, and that this alternative test was really just sort of marginally positive. He has a very stressful job. He has a demanding job in R&D at this company. He is on the SAD diet, the standard American diet. He has coffee and pastry for breakfast. He has lunch meetings, dinners on the run because his kids are all in sports. And he has never slept more than 5 hours. And it's worse now that he's sick. And other than these outings, these hunting trips, he really doesn't get any regular exercise. He has a very high stress life with no real stress management strategy. And his relationships previously have been really good, but he's feeling that they're really strained due to his illness. He had acne as a teenager and in college, and was treated with antibiotics repeatedly and often for long courses. And he has GI issues that started in college, were initially related to stress. Recently, he's been diagnosed with IBS. He has lots of gas, bloating, constipation, diarrhea, and stress, anxiety, and depression. Past medical history, obviously the acne and IBS, his stress in relationships, his social history, his physical exam, he has a rapid heart rate. He has some central obesity with loss of muscle mass. He has mild general abdominal tenderness, and he has loss of vibratory sense. Now, this is an interesting test, and it's commonly positive in Lyme. So you put your finger on the bottom of his first metatarsal, say, and you whack your tuning fork, and you put it on the top. And so what you're feeling is the vibration going through his skin, through his bone to your finger, right? And you do that, and then you look at the patient and say, well, tell me when you don't feel it anymore. and they say, don't feel it, and you still feel vibration. So that is abnormal vibration by confrontation. Now you do that same test, but this time you have the patient's significant other that came with them, their friend, their spouse, their whoever, and you put their finger underneath and you whack it and you put the stethoscope, you put the tuning fork on top and you wait and you see, and you say, okay, patient, okay, John, in this case, tell me when you don't feel it. And then John's friend or wife or brother or whoever still feels it. And their eyes get as big as saucers. It's like, well, that's not normal, because often you can feel it really well when the patient can't feel it anymore. So that's an interesting test. And I would encourage you to start doing vibratory senses on your patients. You'll be surprised at how many people have small fiber neuropathy. All right, so let's do a little poll. If I can get the slide to change. And here's our poll. So our poll is, do you sometimes test for chronic infections on patients presenting with psychiatric symptoms? Now, I used to do a case study of a young lady who actually developed bipolar disease with hallucinations from Lyme and Babesia, but I've changed it to John in this year. So do you sometimes test for chronic infection on patients presenting with psychiatric symptoms? And we're getting more yeses, but we're fighting at about 50-50. We're fighting at about 50-50 for yes or no. And I don't think you should test everybody with psychiatric symptoms for Lyme, but I think in people who have weird symptoms in addition to psychiatric symptoms, it would be a really good idea. And I think in anybody who travels to, plays in a Lyme endemic region, definitely should be tested. Now, there is no state in the country that doesn't have Lyme, as we discussed yesterday, but there are places that are more hotbeds, right? All right, so about half of you do. And here we go. Here's John's timeline. So let's talk about this timeline from the 40,000 foot view here, 50,000 foot view, or whatever foot view you want to think about. And think about the stair-step nature we're seeing. Here's a little bump, a little bigger bump, another big bump, and then a bigger bump. And this is what we usually see. It's not, oh, I was perfectly well and I got chronic Lyme disease. There are antecedents, triggers, and mediators, and there are antecedents for why people get the chronic form. And you almost always, and I know Priya did a non-CME thing this morning about the living matrix. So she showed you this, but that's what this is. And you often see this stair-step nature on the matrix. And so what are we looking at specifically? We see fatigue, way back when, difficulty falling asleep, lifelong insomnia, fatigue and night waking, and then headaches and joint pains and muscle pains. And then so he's 52 or whatever, 20 years prior, he had started having problems. So, it's in this region where he's, probably developing Lyme, and then he's diagnosed with fibromyalgia, and then he has this irritability and urgency and chest pain, and all of these symptoms just are piling and piling and piling on. And then here is this matrix. And again, the white part in the center over here, this stop sign looking thing, that would be ideal. And any orange you see would be excess symptoms in that area of the matrix. So lots of them in defense and repair, lots of them under energy and biotransform and transport and communication. So he's got issues around the board, but we sort of decided that, the major points of leverage are his gut, because unless there's a compelling reason to do otherwise, you start in the gut. And then, of course, defense and repair, because we believe it's a chronic infection. And then probably communication, because of his central obesity and muscle mass loss, right? And your mileage may vary. So you may have chosen other areas, and that's okay too. So antecedents, poor modifiable lifestyle factors, and some genetic issues that we'll talk about in just a minute that we found. And I'll tell you why I did a genetic test. Triggers, tick bite, obviously, there are others. Mediators, ongoing oxidative stress and inflammation. And then we talked about the major leverage points. So we've taken the case, we've looked at the matrix, we've looked at ATMs. So let's talk about vetting his prior diagnoses. So he had seronegative RA. Well, you expect the seronegative RA to declare itself in some point and convert to seropositive RA, which never happened over these 20 years. Also, he does not have typical RA distribution of joint pain, nor does he have early stiffness, nor does he have joint swelling. So I went through all of that with him, and we just crossed that one off. Depression. Well, he feels terrible, no question, but his Beck inventory is only 8. So the way he feels terrible isn't typical of depression. His stress score, his Penn State perceived stress scale was 32. His age norm was 11 or 12. So he's quite stressed. And then the story. Well, the story evolves in these cases because we need to do some labs looking for bugs and whatever else. So we're going to start the story, and we started it with his RA and his depression and all that business. And, I'm telling him why I think he has Lyme and so on. But John's been there, done that, bought the t-shirt. He's a skeptical PhD. So I needed something to grab his attention with. And I decided to use some genetic testing. And so I ordered a genetic screen, and he had a lot of SNPs, interestingly enough. He had several SNPs in the inflammation cascade. He had a number of SNPs in the oxidative cascade. He had a number of SNPs in his histamine cascade and in his energy expenditure and recovery. So that was a way for me to really talk about antecedents with him and to help him understand why he was the unfortunate one who got this weird condition called chronic Lyme, when most people who get Lyme just fight it off on their own. We did an organic acid profile also. The organic acid profile shows poor B vitamin utilization. So he had an elevated FIGLU and elevated methylmalonic acid and a bunch of other findings as well. He was shown to have dysbiosis. He was shown to have low glutathione. He was shown to have oxidative stress, both in the fat and the DNA adduct compartments. He was shown to have mitochondrial dysfunction, specifically between alpha-ketoglutarate and succinic acid. Now, that's a step that requires B1, B2, and B6, as I recall, and I could be mistaken on that, and is inhibited by heavy metals like mercury, which we found. And interestingly enough, there are certain yeast metabolites that can inhibit that step as well, because some yeast use beta ketogluteric acid, and that guns up alpha ketogluteric dehydrogenase. He didn't have any other markers for yeast, however, so I put that on the back burner. He had low omega-3 fatty acids, and as I already mentioned, he had elevated mercury. So I sent off yet another Lyme test. I guess this is the tiebreaker or something, from a different company that looks a little differently at things. And he was negative for Borrelia burgdorferi. So I guess he doesn't have Lyme. Well, wait a second, because he was positive for a different species, Afzelii. And this is known to cause Lyme symptoms. He also had what appeared to be blooms of Epstein-Barr, CMV, and HHV6. And then I sent off some immune markers. So I sent off a CD57. His CD57 was less than 20. And on this lab, that means below the detection range. And then C4A should be less than 2,800. It was 35,000. So these are not diagnostic, but this just tells us that he has an immune response happening that is consistent with Lyme disease. And let's not forget that 70% of the immune system lives associated with the gut associated lymphoid tissue. So not only when in doubt, start in the gut, but unless there is a compelling reason to do otherwise, start in the gut. But don't fixate on the gut. Remember, we're going to lap. We're going to lap. And how do you lap it? How do you start in the gut? Well, we remove, right? And we've talked about this ad nauseum, right? But we're going to remove. And how do we remove in his case? An elimination diet. And in this case, it's actually a renew diet. And you'll see that in a minute, but that's a type of elimination diet. And we're going to use colostrum. Why? Because colostrum has antibodies in it. Cows make antibodies against all kinds of things, but not generally against probiotic species. So we're going to give them colostrum. It's going to help retard the growth of less desirable bacteria without interfering with the growth of more desirable bacteria. Plus, it has immune support in it. It has growth factors in it. And then we're going to use one of our mysterious anti-inflammatory medical foods. And then replace. We're going to use enzymes. We're going to use the anti-inflammatory food because it has vitamins and so on that we want to replace. And then reinoculate. We're going to use prebiotics. Now, the medical food has some probiotics in it, so I should have added that under reinoculate. But we're going to use prebiotic powders as well. And remember that probably the best marker of a healthy microbiome is diversity. And so how do we create diversity? We create diversity with diversity of the kinds of fiber you present to the gut. So you want to pick a probiotic powder that has lots of different soluble and insoluble fibers. And I will sometimes actually use two different ones because this one is heavy in these probiotics and this one is heavy in these probiotics because I want diversity. And then repair. Again, the anti-inflammatory medical food, extra glutamine to help heal the gut, the extra antioxidants, extra multivitamin, and I really should have added in the colostrum here because that's going to help repair the gut as well. And then rebalance. This is the place where, remember the books I talked about, the rebalance, the sleep, the stress management, all that stuff. This is where we get off of the recycling of symptoms, you know, where we did everything, their gut's looking really good, and then they immediately go back to having a bad gut because they never changed their fundamental lifestyle. And then
it's 10:30.
How do you detoxify? Well, you want to reduce the total toxic load. So in his case, it's this organic Renew diet. We're going to use non-toxic cleaning products and personal hygiene products. And then optimize biotransformation. Well, this medical food has phase 1 and phase 2 support. And then we made sure to have them eating plenty of cruciferous vegetables as well. And then increase mobilization. Well, we're going to make sure he's well hydrated. So we're going to flush out the fluid compartment, you know, the hydrous compartment. But we can also do an oil change. And there's some interesting studies in the Ayurvedic literature about using ghee to push out soluble or fat soluble toxins. And so I use ghee, but I use it in a combination. So I use flax oil because I want an omega-3. I use olive oil because that's an omega-9. I use coconut oil, couldn't remember it, coconut oil and ghee. And I give them a teaspoon of each twice a day. So that's, 4 teaspoons of fat twice a day. That's a lot of fat. And you're thinking, this guy's got central obesity and he's, blah, blah, blah. What are you doing? Well, what I'm doing is trying to detoxify him. And he probably has central obesity because he's toxic, among other reasons, right? And because his cell membranes are not fluid and responsive to cellular signaling. So this strategy will probably help resensitize his insulin as well. Okay, so then how do we decrease redistribution and increase excretion? Well, luckily, we already started him on a 5R program. So that's how we're going to do that. So what's our plan? Well, we cleaned up the modifiable lifestyle factors. I suggested he get a Fitbit to monitor his movement and his sleep. I suggested a M-Wave, which is a heart rate variability biofeedback device. This is a direct measure of autonomic balance. And I asked him to use it for 20 minutes morning and evening and about every 2 hours for just 3 to 5 minutes to sort of check in with his autonomic state. I asked him to go on this Renew diet plan. And I asked him because he is like, I'll sleep when I die kind of guy. And the beautiful news about that structure is if you choose to sleep when you die, you will get the opportunity to sleep at a younger age because people who don't sleep die younger. And I explained that to him and I asked him to read this book and he came back kind of wide-eyed like, wow, I didn't realize sleep was so important. And you know what? after sleeping, after giving myself that 8-hour opportunity every night for a couple of weeks, it made a big difference. Now, it turns out that Lyme may have some diet susceptibility. We've known for a long time that that Candida is diet susceptible, right? And I think Helen just finished talking about using a low carb diet for Candida. Well, it's hard to grow Lyme in the lab, and we use this BSKH medium, and that has a ton of glucose in it. And so our blood only has 100 milligrams per deciliter, and that's probably why you don't find it in the blood so readily. But going on a low glycemic diet for sure, and a low carb diet even better, is likely a good strategy. Plus, changing your diet alters your microbiome. And so here's a study in mice, which shows that a synthetic diet, and here reads simple carb diet, when they inoculated these mice with Candida, and the recovery rate of that inoculum in the stool was much higher in the synthetic diet here than it was in the commercial diet. And here's a study in humans: rapid and reproducible alteration of the gut microbiome. And over here, we see a plant-based diet, and then here we see an animal-based diet. We just see this real significant and dramatic change in diet. So, you know, when we put people on an altered diet, is it because they were food sensitive? Is it because we were reducing inflammation? Was it because we were not feeding the Candida, or is it because it's altering the microbiome in some way? I mean, it's a very complicated and complex system, right? So he's been using him waiting, and we're fighting his fight or flight. And why do we care about fight or flight? Because it alters blood flow to the gut. And that results in functional malnutrition, because you're not digesting and absorbing because you don't have the blood supply. And because you're shunting blood away from the GALT, the gut-associated lymphoid tissue, you have functional immunosuppression. And it increases gluconeogenesis, which we just talked about. We wanted to try to